Good evening, everyone, and I'd like to welcome you all to the March 31st edition of CAEP National Grand Rounds. My name is Hugh Borgenvag, and I'm honored to be the moderator for this evening's presentations. I'm an emergency physician and a clinician scientist at the Schwartz-Reisman Emergency Medicine Institute, that's abbreviated as SHREMI, at the Sinai Health System here in Toronto. I'd like to begin this evening's rounds by acknowledging that while this is a virtual event, the land we are all speaking to you from is the traditional territory of many nations, including the Wendat, the Anishinaabeg, the Haudenosaunee, and the Confederacy of the Mississaugas of the Credit and the Métis Nation. Today, the meeting place of Toronto is home to many diverse Indigenous peoples from across Turtle Island, and we also acknowledge that Toronto is covered by Treaty 13, the Toronto Purchase with the Mississaugas of the Credit. So I'm very excited about this evening's talk. We have a lineup of 3 great speakers, and our focus is going to be on really the management of patients who have alcohol use disorder in the emergency department. The first speaker we're going to hear from is Dr. Hassan Sheikh on the ED management of alcohol withdrawal syndrome. Our second speaker tonight will be Dr. Michelle Clayman, who will be speaking to us about the medical management of alcohol use disorder in the emergency department. And then our third speaker will be Dr. Dave Dushensky, who will be discussing the ED management of the agitated patient, specifically in the setting of alcohol use disorder and alcohol withdrawal. I'd like to do just a little bit of housekeeping. Tonight, the format for this evening's presentations are that there will be 3 15-minute presentations, each one followed by 5 minutes for questions. I'll ask you to please put your questions in the text box. They will be transmitted to me, and then I can ask them on your behalf. And I'd like to also thank those of you who submitted some questions in advance. We'll be sure to get to those. I'd also like to let everyone know that CAEP's Scientific Planning Committee has reviewed declarations of conflict of interest, and there are no conflicts, perceived or real, that have been identified, and that there are no external supports received for this webinar. But before we start our first presentation, we're going to go to a short video from CGEM's Dr. Catherine Patoka with some comments about the January edition of CGEM.
Hello, my name is Catherine Patoka. I'm an emergency physician in Calgary, Alberta, and I'm also a decision editor for the Canadian Journal of Emergency Medicine. In that capacity, I wanted to briefly highlight one of the articles that came out in the January 2021 edition of CGEM, and that's a study by McLean et al. Looking at First Nation members' emergency department experiences in Alberta. This was a participatory research project which respected both First Nations and Western ways of knowing that highlighted First Nation members having both positive and negative experiences in the emergency department. Some of the positive experiences centered around work with Indigenous hospital liaisons, whereas negative experiences included stereotyping, racism, and fears of child apprehension. The authors concluded that in light of these findings, emergency physicians should reflect on the care that they provide in the emergency department and look for opportunities to improve the care of our First Nations members. I think this study highlights a few really important things. One is that it applies to emergency physicians across Canada. CGEM is not just for researchers, and you can definitely find nuggets of really important and valuable information for the care that you provide to Canadians. Secondly, CGEM is not all about quantitative randomized controlled trials and systematic reviews. You can find elements of qualitative research which can improve and impact your care. Finally, as a CAEP board member, I just wanted to highlight that equity, diversity, and inclusion are definitely front and center in the work that we're doing, as they are reflected in some of the core values that CAEP has devised, which include accountability, respect, integrity, inclusion, and service. Thank you very much for your attention, and I hope that you enjoy CAEP Grand Rounds.
Thank you very much, Catherine and CGEM. So now on to this evening's presentations. Our first talk is going to be on the ED management of alcohol withdrawal syndrome, and that'll be presented by my colleague here in Toronto, Dr. Hassan Sheikh, who's an emergency physician and addictions physician, as well as a clinical researcher at the University Health Network. He's the medical lead for the Toronto Western Hospital Rapid Access Addiction Medicine Clinic and a lecturer at the University of Toronto. He has a master's degree in public health administration, and his research focuses on using the emergency department to diagnose failures in public policies. Hassan, looking forward to your presentation.
Thank you much, Bug. Let me just pull up my slides here. All right. So thank you so much. I'm excited to talk to you all today about the ED management of alcohol withdrawal. There are basically 5 main things I want to cover today. The first is about recognizing alcohol withdrawal. Secondly, I'd like to talk about symptom-triggered management, in particular, what medications you're going to use and at what doses, what frequency. Then I want to talk about refractory alcohol withdrawal, how we define that, what are our treatment options. And then we'll touch a little bit about disposition, who gets admitted, who goes to the ICU, who goes home. And then the last thing I want to do is kind of take a step back and just talk about, why is this a big deal and why is it really important that in the emergency department, we become masters of treating alcohol withdrawal. So first up is recognizing alcohol withdrawal. Now, there are these 4 different kind of constellation of syndromes that we really consider as alcohol withdrawal. And we're going to focus on acute alcohol withdrawal syndrome, or AWS, today. But it's important to recognize that this is not necessarily a linear progression, and that patients can present with alcohol withdrawal seizures or alcoholic hallucinosis or delirium tremens and not necessarily manifest obvious AWS first. Now, alcohol withdrawal syndrome typically presents 6 to 24 hours after their last drink, and it usually lasts about 2 to 3 days, but can last up to 7 days. And I think a lot of us, kind of understand the symptoms, and it's this hyperadrenergic state that comes from the removal of a depressant in alcohol. But the real hallmark of alcohol withdrawal syndrome and where it distinguishes itself from other hyperadrenergic states is the tremor. And that's really what I focus on. Now, the tremor is an intention tremor. It's about 7 to 12 hertz. It's constant, and it doesn't fatigue. And if you're, unsure kind of when you get the patient to hold out their arms and spread out their fingers, and you're not quite sure if it really is a true alcohol withdrawal tremor, one of the things you can do is to look for a tongue tremor, which will happen around the same frequency. Again, doesn't fatigue and is very hard to fake. If you've ever tried it, it does not look particularly good when you try to do it yourself. Important, it's to recognize that the CWA is not a diagnostic tool. You have to make the diagnosis yourself, and then you use the CWA as a way of tracking your response to treatment. So once you've made the diagnosis, then we move on to something called symptom-triggered management. And that's typically with the CWA protocol, although there are other scales out there. And the idea is that, if we're going to use these scales to basically grade the severity of alcohol withdrawal and then treat with benzodiazepines, most often diazepam, rather than a kind of fixed dose schedule. And what this has been shown is to reduce the duration of therapy and, in fact, reduce the total diazepam dosage. And if you look at the 10 things that are on the CWA scale, there are prompts out there and there's some guides about how you grade it. And a lot of people will often say that it's a challenge to kind of standardize the assessments from, provider to provider. So for example, if you look at the tremor, 0 is no tremor. 1, I'll put my hand on there, my fingers on the patient's fingers. You can feel the tremor, even if you can't see it. But often kind of that 3 to 7 is a bit hard to grade. What exactly is moderate? What exactly is severe? So what we did at in our department is a QI project to try and standardize this. And one way that you can do this is to get the patient to drink a cup of water. You can give them a cup of water, and because it's an intention tremor, that will bring it out. And in that kind of 1 to 2 tremor range, there's a little bit of a tremor that you're seeing. 3 to 4, it's pretty noticeable, but they're still able to drink a cup of water with one hand. In that 5 to 6 range, you're seeing that they need both hands to drink that cup of water, and at a tremor of 7, they're unable to get it to their mouth. And once you've kind of set your CWA, you've determined the severity of this, then the question is, which benzodiazepine are you going to use? Now, diazepam is kind of the main one we think of, and I think it's important to understand the properties of it and why it's ideal for alcohol withdrawal. So diazepam peaks fairly quickly, so its onset is quite rapid, but it's got a very long half-life of about 2 to 3 days. So that's ideal for alcohol withdrawal, because what you're getting is that within the hour normally, you've kind of hit your peak of diazepam. And so when you redo your CWA scores and you're going to give them another dose, you're not going to dose stack because you've already hit your peak, and then you're going to give them an additional dose. And then because the alcohol withdrawal syndrome is going to last, usually about 3 days up to 7 days, the diazepam is going to slowly taper in their system over that time course and cover them so that you don't need to give them a prescription for a benzodiazepine to go home. Now, you'll often see the alternative agent being lorazepam. And the reason why lorazepam is not as ideal an agent is because, it peaks a little bit later than diazepam, but it's really that half-life of only 12 to 14 hours, which means kind of once the lorazepam is worn off, the alcohol withdrawal syndrome features could all come back. And so, it's not the ideal choice. And the reason why it's usually recommended is in patients with liver dysfunction. But in patients with liver dysfunction, the reason that they recommend against using diazepam is because there are metabolites of diazepam that are cleared by the liver. But what's important to know is that those metabolites are not more potent than diazepam itself. So that means that the peak is going to be the same, but the half-life is just going to be extended. And so the half-life is about 3 to 5 times longer in people with liver failure. But if you're thinking about the properties that we want out of a medication when we're treating for alcohol withdrawal syndrome, you still get that peak at the hour mark, so you're not going to dose stack. And in fact, these patients experience some of the smoothest tapering because it just kind of tapers in their system over a longer period of time. So I use diazepam in all patients, including patients with liver dysfunction. In terms of what dose of diazepam to use, we don't have great studies on this. We do have a little bit of data from a while back from before CWA protocols that looked at 2 hospitals in Toronto and kind of the mean doses that they were giving of diazepam and what the rates were of seizures and other complications. And what they found was that higher doses had a lower seizure rate. Now, this is a retrospective study, but it's pretty good data because, in fact, you might think that you would get the opposite result, right? That a higher dose of diazepam, higher seizure rates, and it would be more that the population was different between the 2 hospitals. But the fact that the higher mean dose of diazepam hospital had a lower seizure rate is suggestive that, we can probably push the dose and that bit more aggressive dosing is better. So here's what I do and what our hospital has recently adopted in our order set, which is for most patients, I'm giving 20 milligrams of diazepam every hour for CWA greater than 10. These are pretty GABA tolerant patients. And so to give them, low doses of diazepam, you're really never going to get ahead of where you need to go. If someone is, I'm worried about their respiratory status, say they're on chronic opiates like methadone, they have respiratory depression from asthma or COPD or COVID, they're elderly, then I might use a lower dose and then reassess. And that reassessment piece is really important. This isn't something where you just sign the order set or write the orders and walk away. If you're not getting a meaningful decrease in your CWA scores, then you need to increase the dose of diazepam. So typically after about 3 doses, I consider doubling it. And I had this case a while back that really reinforced this for me. I was getting handover from one of our docs who was leaving, and they were telling me about a patient that they were going to refer to internal medicine for alcohol withdrawal. And that always gets me thinking because I don't refer a lot of these to internal medicine. And I said, actually, you know what? I'll take the handover. Let me see what I can do. And this was a young guy who over the course of about 8 hours had gotten 60 milligrams of diazepam, and his CWA scores were still in the low 20s. And so I went, I assessed him, gave him 40 milligrams of diazepam. CWA score dropped to about 12, 13. We gave him another 40 of diazepam, and his CWA score went down to like 3 or 4. And after a couple hours of observation, he was happy, he wanted to go, he felt great. And so it was really just about getting a higher dose of diazepam in his system, and one that was going to really get ahead of the withdrawal. For those with complicated alcohol withdrawal, withdrawal seizures, DTs, you can consider giving a loading dose of 20 milligrams of diazepam for 3 doses separated by an hour, and then start your CWA protocol. Now, in terms of refractory alcohol withdrawal, we don't have a standard definition. My personal practice is that I kind of start to think about refractory alcohol withdrawal in that 140 to 200 milligram mark. And if I'm not getting enough of a response to the diazepam at that point, I start to think about, well, what are the 2 mechanisms that alcohol? And benzos, they work on the GABA channel by increasing the frequency with which those channels open, but they don't really have much activity on the NMDA receptor. Phenobarbital is my go-to second-line agent. It works a bit differently than benzos by keeping the GABA channels open longer, and then it also has some glutamate inhibition. It's also got properties that make it very similar to diazepam. It peaks quite quickly, and then it's got a long half-life, even longer than diazepam, about 3 to 5 days. And so I start at a fairly low dose of 65 milligrams, and I double each dose to try and get to that CWA score less than 10. Other people have used propofol and ketamine to kind of target that NMDA receptor antagonism. The properties are not as ideal in terms of the half-life, but with either of these options, I think I would be starting to get our ICU colleagues involved. That brings us to disposition. I think there's kind of the complicated alcohol withdrawal, which you're going to want to refer to your internal medicine teams in terms of non-resolving alcoholic hallucinosis, multiple withdrawal seizures, DTs, suspected Wernicke's. But when it comes to just the kind of quote unquote simple alcohol withdrawal syndromes, our goal is to kind of bring those CWA scores less than 10. That's the kind of endpoint of our CWA scores, our CWA grading system, where you're not giving any diazepam in between. And as we talked about, because of the long half-life of diazepam, these people don't need a benzo prescription. Now, I also want to try with all of these patients to offer them a bit of hope. One is to keep them a bit more comfortable, because even though their CWA score is less than 10, it's usually not 0. So they'll have some lingering alcohol withdrawal symptoms. And I'll typically use gabapentin, 300 milligram TID for a week to help with that. I'll offer all of them anti-craving medications. Dr. Kleinman's going to talk more about that next. And then always kind of try and connect them to the local addiction medicine resources in the community. For those that I'm admitting to hospital, as I said, it's pretty rare that I'm referring someone to GIM, because if you think about it, what can they do? Essentially, they do what we do in the emerge, but slower, because they can't really do the assessments as frequently. And so it just means prolonged discomfort for our patients. Now, the odd time and the rare circumstance where I will refer to GIM is in the patients who have ongoing alcohol withdrawal symptoms, but are also experiencing respiratory depression from the diazepam. So occasionally you'll get this situation where the person's getting a bit drowsy, nodding off, but you wake them up and they still got a pretty significant tremor. Those people need, our typical CWA protocols, but a little bit more spread out, a little slower, and GIM is a very good place to do that. And then for the ICU, I'm sending, the people with refractory alcohol withdrawal requiring the adjuncts and a bit more closer monitoring of their respiratory situation. And finally, I just want to take a step back and talk about, what's the big deal? We learn in med school that alcohol withdrawal can be dangerous with seizures, but, most of these things are pretty simple. And I would like to point out that simple doesn't mean it's safe. So this is a study that I was part of that was recently published in CMAJ. And what we looked at was all visits in Ontario for alcohol-related reasons. And these were mostly kind of these simple visits, simple intoxication or withdrawal. And if you had 2 visits in a year your 1-year mortality was 5%. And if you had 5 visits in a year, your 1-year mortality was almost 10%. And that's like MI territory. So these are sick patients. And the Kaplan-Meier curve really kind of tells the story for me, which is you can see this drop off in survival after multiple visits in the emerge. And so the takeaway for me from this study is that these are our patients. If someone with heart failure has a worsening of their condition, they're more likely to call their cardiologist, they're more likely to call their family doctor. But if someone has an acute exacerbation of their alcohol use disorder, they're less likely to see their family doctor or an addiction medicine provider. They're more likely to end up on our doorstep. And I think the story that comes out of this is that this is a population that has frequent contact with the healthcare system, and despite that, is having very poor outcomes and high mortality. So in summary, we talked about recognizing alcohol withdrawal, and really I focus on the tremor. Talk about symptom-triggered management. I use diazepam for all these patients. Talked about refractory alcohol withdrawal and why phenobarb is probably the best choice. Talked about the disposition, where you want to make sure that CWA score is less than 10 for 2 readings. And then in terms of what's the big deal, why do we need to become masters of this? It's because the mortality is high and our patients desperately need our help.
That's great. Thank you very much, Hassan, for those for that talk and that very interesting presentation. I do have a couple of questions that have come in. Here's one from Maria Ivankovic at St. Joe's here in Toronto. And this is an important question. Do you admit most patients presenting with alcohol withdrawal seizures, even if the CWA is like less than 8 for 3 times? She says she sees lots of practice variation. She wonders what the expert recommends.
Yeah, I think if they're having recurrent seizures, I will then refer these patients to be admitted. The typical kind of course of an alcohol withdrawal seizure, they're usually quite brief. They're kind of, grand mal, non-focal seizures, but they're usually brief and resolve fairly quickly. And so if you're kind of getting multiple seizures and needing, to respond to them multiple times, then I would start to get concerned and refer them on to be admitted.
Great. I think we have time for one more question. This one comes from Chantal Duvernay, and she asks, are there any concerns or strategies for patients who present frequently wanting symptom management for alcohol withdrawal? She says, would you be more hesitant to prescribe a few days of benzodiazepines for these patients?
Yeah, so as I mentioned, I don't tend to prescribe benzodiazepines for this group. I tend to treat them aggressively and quickly in the emerge. And I think that sets them up the best for success. And it means that the other nice thing about that is I don't have to worry about, a lot of people will ask me, well, what about the subjective complaints of alcohol withdrawal? And they have no objective features, or I think this person just more benzos. And I don't really mind giving additional benzos in the emerge because I'm loading them and then I don't have to worry about a prescription. So that's my preferred practice.
Great. There's a question here from Ken that I'm going to wait until we get to Michelle's talk. And then there's a question here from Joel Lection also. Joel wants to know, does good management and disposition lead to lower mortality rates? And I recognize you may not know the answer to that question.
Yeah, I don't think we have the studies on that. And I don't know that we've been doing good enough management to really make that impact, but we certainly should be striving for it.
Great. All right. Thanks very much, Hassan. I think with that, we're going to move on to our next speaker. So our next speaker, as I mentioned, is Dr. Michelle Clayman. She's an emergency physician and addiction medicine colleague from St. Michael's Hospital here in Toronto, where she also works in a RAM clinic. She's an academic physician focused on improving the care of those presenting to the emergency department with alcohol and substance-related complaints. She's contributed to local, provincial, and national guidelines on the management of substance use disorders, and she's an assistant professor at the University of Toronto. Michelle, over to you.
All right, so today I'm going to be talking to you about anti-craving medications. I'm very thrilled to be here, and I'm hoping that I can share some knowledge that is not only practice changing, but also has the potential to really improve the lives of those with alcohol use disorder in the emergency department. My goal at the end of this is really to empower you to prescribe anti-craving medications in the ED. So I have one case, and this is a case we see all too often in the emergency department. I'm sure on my last shift, I saw 3 of these patients who came in stating that they drink too much. This particular patient that I have in mind is a 35-year-old, has an alcohol use disorder, has been diagnosed, drinks 1.5 liters of wine per day, plus some shots. She was drinking in the courtyard, and somebody called EMS after she passed out. Now, alcohol, it affects so many, as we heard, and often this is kind of our instinct. DC home when patient is awake, alert, and ambulating safely. Maybe you do this: screening, brief intervention, and referral to treatment. But what I'd really love for you to do is this: screening, brief intervention, referral to treatment, and starting an anti-craving medication. Alcohol affects so many in Canada. It is by far the most common drug used by Canadians. In 2015 to 2016, there was a study published that showed that there are more hospitalizations in Canada. This was a national study, entirely caused by alcohol compared to those due to ACS. And that number is pretty high. The number was 77,000. So there were 77,000 admissions in Canada directly related to alcohol in a 1-year period. And that's compared to 75,000 directly related to ACS. So this is a very big problem. We heard about the mortality in Hassan's paper. They looked at over 25,000 visits in a 1-year period in Ontario, and they adjusted for age, sex, income, rural residence, and presence of comorbidities. And the overall all-cause 1-year mortality, as Hassan mentioned, was 5.4%. And what struck me about that study was the all-cause mortality if somebody had multiple visits to the emergency department. So if they'd had greater than 5 visits, the all-cause mortality within a 1-year period was 8.8%. And that number is striking for me. It really affected the way I look at this. Despite those very high numbers, there's been studies showing that less than 10% of patients with alcohol use disorder ever receive an anti-craving medication. And it boggles my mind because these medications are very effective, have very few side effects, and are incredibly easy to prescribe. And I'm going to talk to you about some of them today. So the first line medication, and this is a medication that Hassan mentioned as well, is naltrexone. And as you know, this is an opioid antagonist. This is the oral form of naloxone. And the way that it works is very interesting. When somebody drinks alcohol, it releases endogenous opiates. Those endogenous opiates bind to the mu opiate receptor and increase dopamine. And that dopamine is what really drives the pleasure and reward. So naltrexone acts by blocking the mu opiate receptors and preventing the dopamine release after the endogenous opiates are released. And it is quite an effective medication. It reduces the number of heavy drinking days. It decreases the amount consumed if people are drinking. And it decreases daily drinking. And certainly it does increase abstinence. The number needed to treat the heavy drinking is only 12, and it is 20 for return to heavy drinking. So this is a very effective medication with a very low number to treat that is very safe to prescribe in the emergency department. The dosing is quite easy. It's 50 milligrams PO/OD. In some cases, you might see patients started on 25 milligrams, and that's to mitigate some of the side effects caused by naltrexone, primarily GI upset and headache. But I tend to start at 50 milligrams, and we are prescribing up to 100 milligrams if it's not effective. The one thing to note is the contraindications. If the LFTs are 3 times the upper limits of normal, naltrexone is not an appropriate medication as it is hepatically cleared. So we do avoid naltrexone in patients who have severe liver dysfunction, and that would not be our first choice. If somebody does have decompensated liver disease with their liver enzymes 3 times the upper limit of normal, the other first-line medication is acamprosate. Acamprosate is a glutamate stabilizer, so it's thought to help with the protracted symptoms of alcohol withdrawal that leads to ongoing drinking. is particularly effective in those who have been abstinent for 2 days. So again, might not be our first choice in the emergency department unless somebody has been abstinent for 2 days. But it can be used if patients have liver disease. It has a very similar number needed to treat. So a meta-analysis, which was done in 2014, showed that the number needed to treat is only 12 for return to any drinking. So again, a very, very effective medication. The dosing is 333 milligrams, 2 tabs, so it's 666 milligrams orally 3 times a day. And this is why this isn't my first choice of medication, even though it has a very similar number needed to treat as naltrexone. It's because it's a medication that people have to take 3 times a day. And if somebody has so much chaos in their lives, they might not remember to take it. So that's why I tend to prescribe naltrexone unless there are contraindications. It's renally cleared. So if the creatinine is less than 50, you want to reduce the dose by 50%. So that would be 333 milligrams 3 times a day. And if the creatinine clearance is less than 30, then it is contraindicated. There are multiple anticonvulsants that have undergone various studies. Topiramate and gabapentin are the ones that we use the most. There is some studies showing that topiramate may reduce the number of heavy drinking days and the number of drinks that somebody consumes on the days that they drink. It is particularly helpful in patients who have a concurrent stimulant use disorder. So this could be an option in patients who have an alcohol use disorder as well as a cocaine use disorder. And then gabapentin is a medication that we prescribe a lot, mostly for alcohol withdrawal. However, there are studies showing, there's 3 RCTs actually showing that it can help people reduce the number of heavy drinking days, and especially if it's combined with naltrexone. And the distinct advantage of gabapentin, as you heard, is that we use it very often for protracted withdrawal symptoms. So it really helps with the feelings of anxiety and insomnia that people feel subacutely after they stop drinking alcohol. And often we do continue it down the road if it is helpful for the patient. So this is another medication that you can prescribe for patients as an anti-craving medication and also as a medication to treat their withdrawal. The dosing is 300 milligrams PO/TID. So the question always comes up, what do we do in pregnancy? We might be seeing gravid patients in the emergency department, but maybe we're seeing patients who are very early in their pregnancy and who have an alcohol use disorder. Unfortunately, there are no clinical trials evaluating possible options for the pharmacological management of alcohol use disorder during pregnancy. But overall, you have to weigh the benefits and the risks of a medication with the risk of relapse to alcohol. Naltrexone is considered category C, but 4 studies show no negative effects to the pregnancy or fetus when used in treatment for opiate use disorder, although there are no studies for alcohol use disorder. There is a group out of St. Mike's here in Toronto that has done a recent case series of 4 patients who they treated with naltrexone, and they found the medication to be very effective, especially when combined with cognitive behavioral therapy. It increased abstinence, and there are no reported negative outcomes. So hopefully that case series will be published soon. In terms of a camprosate, it is also category C. However, ondansetron is a potential additional medication that we can use. So ondansetron, as many of you probably know already, prescribing it for nausea and pregnancy, it is category B. And there's actually 3 studies, limited quality, but shows that it can be helpful to decrease alcohol consumption in combination with cognitive behavioral therapy. So it is often a medication that is trialed in patients who are pregnant to help prevent them from consuming alcohol. One of my colleagues, Dr. Suzanne Turner, who is an expert in substance use in pregnancy, has told me that alcohol is category X. And when you compare that with the category C, maybe the category C is not so bad. So naltrexone and camprosate and ondansetron, obviously none of them are contraindicated in pregnancy. The mechanism of ondansetron is not clearly understood, but it may be due to the serotonin antagonist properties at the receptors. So for far too long, our patients have really been treated with a stigma-based to approach. A notion that maybe prescribing anti-craving medications for alcohol is not in our wheelhouse. And beyond treating them for their withdrawal and maybe referring them for treatment, there's not much we've historically been doing. So I hope this talk has given you the tool that you need to start prescribing these medications from the emergency department. And we always think about follow-up though. So what if we start a medication that can't be, but we haven't arranged follow-up in the community? You can write a 4-week prescription and then the patient can always follow up with their family physician or a walk-in clinic. Any physician can prescribe these medications and they really do require very little follow-up down the road. They don't need to be monitored, no blood work needs to be taken, but they will help your patients reduce their drinking. And if you have any questions, I'm happy to answer them. My email's at the bottom there. Thank you.
That's great, Michelle. Thank you very much. I might have missed this because I was jiggling between 6 windows on my computer to see which questions were coming in, but and so maybe you answered and I'm sorry. So you write these prescriptions and start these patients on these treatments directly in the emergency department?
Yep, 100%. Yep. If a patient is open to it, then we have a discussion and I do it. And I don't necessarily do LFTs for naltrexone, only if there's any concern around a previous history of decompensated liver failure.
And generally speaking, how long do you write prescriptions for and how much do these medications cost?
So that's a great question because it's going to vary province to province. In Ontario, I can speak to our ODB, so they are covered. Naltrexone and acamprosate are covered by OW and ODSP, so our social assistance. So they would be free of charge to the majority of our patients, and they are covered by most private drug plans. If somebody were to buy a 1-month prescription, the last time I checked, it was around $150 for a 1-month prescription. And I'll prescribe anywhere from 2 weeks to 4 weeks, depending on when they're able to get follow-up. And we're very lucky that we do have really good access to rapid access clinics here in Toronto.
Great. Thank you very much. I haven't seen any other questions coming in. Let me check one of the 8 screens that are open at the minute. But if there aren't any other questions, here's one from DePorres. How long does one have to take the anti-craving medications for?
That's a great question. It's going to be entirely dependent on the patient and what treatment they engage with, right? So we know that if somebody takes these medications on their own, they're not going to be a magic pill, right? So it's not like they're going to take naltrexone or acamprosate or gabapentin and suddenly stop drinking, really. Right? It needs to be combined with the appropriate psychosocial supports, cognitive behavioral therapy or DBT. They really do need to engage in other forms of treatment. And so that's really going to dictate how long they stay on these medications for. I have patients who are on these medications for years. I have patients who are on it for 6 months and say, you know what, I've gone to treatment and I feel okay and I'm ready to stop.
Okay. I have one other question. This is from Scott Odorizzi. Can you have patients on a couple of these medications at the same time? So naltrexone and acamprosate, or one of these drugs and gabapentin?
Yeah, so for sure with gabapentin, they can be on naltrexone or acamprosate, which would be the 2 most common ones that we prescribe. There was a study that combines that. There hasn't really been a lot of evidence showing that combining naltrexone and acamprosate is effective, but it could be trialed, but there's just not a lot of evidence for it. So I've tried it a couple of times, but it's not my common practice.
Michelle, can I ask you one more question? If you turn on your camera. Terrific.
Yes, of course.
There was another question from Joel Lection. He's read that in France, people are using baclofen as anti-craving medication. And Joel would like to know if you have an opinion about using that drug.
Yeah, when I was training in my fellowship, there was a study going on at CAMH, and we were using baclofen a little bit for treatment of alcohol use disorder. I haven't really seen it prescribed recently, although there is some emerging evidence that it could be effective, but it's not common practice at the moment, so I don't have a strong opinion.
And then maybe while we're waiting for Dave, I'll ask one other question, and I'll open this one up to either Michelle or Hassan. This is from Brian Steinhardt. What strategy can be used to reduce potential for downstream hepatic encephalopathy when treating alcohol withdrawal syndrome with concomitant severe cirrhosis? Maybe we'll start with Hassan, and then maybe have some time for some comments from Michelle as well.
Sure. Yeah. So, I think in terms of the patient with advanced cirrhosis who presents with alcohol withdrawal, I think it's still very important that we basically have the same strategy, early and aggressive treatment with benzodiazepines. Studies have looked at this and haven't found a high risk of triggering hepatic encephalopathy with short 1 to 2 days of benzos. The risk kind of goes up longer than that, but if you treat early and aggressively, that seems to be the best way to prevent, triggering hepatic encephalopathy.
Right. Michelle, do you have anything to add from your perspective?
I guess one strategy you could use is load with diazepam first. So get those 3 20 milligram doses of diazepam in, so you have a load of the active metabolite sticking around. And then you could always switch to lorazepam if there's any concerns. And I've seen ICU employ that strategy as well. So start with diazepam and then switch to lorazepam.
And if we have time while we're waiting for Dave, maybe one more question. And this is actually just one from me. What do you do when you have patients who get a score high on the CWA, but they really only score high on the subjective components, so they don't have profound tremor, they're not agitated? You got 10 seconds to answer, either one of you.
Sure. Yeah. So as I was saying, these are very GABA tolerant patients. If they're still awake, they're alert, they're scoring high on those subjective complaints, I still treat them, provided I've made the diagnosis of alcohol withdrawal first, because I'm really not that concerned about treating them with benzos in the emerge, and I'm not giving them a prescription to go for benzos as an outpatient.
Yes,
Great.
I agree.
Thank you both very much. Well, in the interest of time, I'm going to keep moving ahead. Thank you very much, Michelle. That was very interesting. And I think it's something that's increasingly interesting to emergency physicians. I need to find, let's see now. So our final talk this evening is the ED management of the agitated patient. And for that presentation, I'll be turning the podium over to Dr. David Dushensky. David is my friend and colleague. Actually, he's the chief here at Mount Sinai Hospital, and he plays an important administrative role here at SREMI. He, along with Paul Hannum from North York General Hospital, are co-directors of our emergency department administrative conference that we hold annually in Toronto. There's a shameless plug for you. He's also co-chair of the Supplemental Emergency Medicine Experience. He's an assistant professor here in the DFCM, and he's interested in ED administration, education, and quality improvement and ED design. So Dave, I'm going to turn the podium over to you, and welcome.
Thank you for all being here today. I'm very happy to be here and now actually talking about this topic. And in preparing for this talk, there was a case from very early in my career that came to mind. I was working a solo midnight shift in ED when we got a call that police were bringing in an agitated, suspected intoxicated male. And that call elicited mostly shrugs from the staff in the emergency department, because we see that all the time after all, until they came through the door. And what I saw when they arrived was 3 of the largest police officers I had ever seen in my life. Each of these guys was like a small mountain, accompanied by one of the largest patients I had ever seen in my life, all of them struggling, panting, red-faced, and drenched in sweat. Now, at that time, midazolam was actually a new drug in the emergency department. Nobody was using ketamine. It wasn't really stocked anywhere. And our approach to managing agitation in patients was much different than what it is now. And I struggled through managing that particular patient, administered more drug than I had ever given to anybody in my career up until that point. And thinking about that case allowed me to sort of reflect on how things have changed. And today, we're going to have the opportunity to review some of the more current management around specifically alcohol-related agitation in the emergency department. And I think it's fair to say that there really is a huge spectrum involved in what we're talking about here. And it ranges from the recreational drinker who's upset in your department because they fell down in a puddle outside the club and got a laceration and ruined their clothes, all the way to the other end of the spectrum where you've got a patient in delirium tremens or with an agitated delirium who could actually die if not aggressively and appropriately managed. And then you've got everything in between that. And we as practitioners have to have an approach to each of these different categories and different tools to manage these that are a little bit more nuanced than just saying for everything, well, let's give them 5 and 2 and then we'll move on. So when I look at this, I tend to sort of think about alcohol-related agitation in the emergency department in different kind of subpopulations. There's our intoxicated individual who comes in who's agitated as a result of the alcohol in their system. There's our patients who come in who are in withdrawal who have the agitation in relation to that. At the far end of the spectrum of withdrawal is the patient with an acute delirium tremens. And then we have the fairly common occurrence of mixed intoxications that show up in our department as well. And then at the complete far end of the spectrum of agitation in the ED is the patient who comes in with agitated delirium, which may not be exclusively related to alcohol, but sometimes has some overlap for us. So when we look at how we approach this, of course, it's always about safety for the patients, safety for the staff, but there are ways of inadvertently making it less safe. And there are actions that we can take in our departments to actually help make it more safe. And it's important that we remember that it's not really the control of the agitation itself that's the end game. This is what is allowing us to complete an assessment and to determine if there's further intervention and treatment that's going to be needed. So I kind of think of it in terms of non-pharmacologic and pharmacologic approaches. And when we look at our non-pharmacologic approaches, de-escalation is really important. And this is a phrase that's bandied about a lot. I think there's probably a lot of people who don't necessarily understand what de-escalation really means. It is useful for the engageable patient. And I think it's really important for us to remember that when we're seeing these people, these are not individuals who are having their best days. And we're not seeing them at their usual baseline. And we have to remember to show them some compassion and some respect. And so as we try and go through and manage their presentations, try and gain alignment. We can provide supportive and explanatory statements, defining some boundaries for them. Say things like, we're here to help you. Things are going to be okay. Here's what we're going to be doing next. I can see how hard this is for you. Thanks for trying to help us out. And wherever you can, as you're going through this process, try and provide control to the patient. We really need to avoid adversarial statements. So telling somebody that you've got more Haldol than they've got angry has never de-escalated anybody in any department anywhere. So we really need to avoid trying to use those types of techniques in the department. The environment can be really helpful in terms of managing this as well. So ideally, and again, we've all got limitations in terms of space and resources where we work, you don't want to be doing this type of thing in front of a waiting room full of people. So if you can, try and remove the audience, because sometimes that by itself can be an escalating factor. Try and find a quiet, non-stimulating space, hopefully somewhere in your department, but somewhere that's observable. You don't want to just shove these people off into the corner and then forget about them. Physical restraint, of course, it can be very important, and you do that only when you need to. If you are doing it, you're all in, you're in 4 points, you don't do partial restraints or anything like that until you've obtained control, and then you can start to de-escalate that part of it in a more sequential fashion. But we also need to keep in mind things that may make the experience much worse for the patient. So if you have 5 male security guards restraining a female patient, try and make sure that you've got another woman in the room who can inform the patient, reassure them, redirect them, because that can be a fairly traumatizing experience by itself. And we don't often know anything about their past traumas and how this may be making them feel in these circumstances as well. So the pharmacologic approaches to alcohol withdrawal, I mentioned before that we need something a little more nuanced than the 5 and 2 of Haldol and lorazepam. And I don't have anything against 5 and 2 of Haldol and lorazepam. It's a very useful treatment and is generally safe for almost all of the patient populations that we're going to see. But I like to think of this in terms of a bit of an analogy. If you've ever gone and played golf, you know that golf is a complex game. You'd never try and go out and play a round of golf with only one club in your bag. Well, agitation is a complex condition, and we need more than one tool in order to be able to approach this adequately. So in sort of general order of comfort and familiarity for emergency department practitioners, the drugs that we tend to see used in these situations are benzodiazepines, antipsychotics and neuroleptics, anesthetic and sedative agents, and then lastly, barbiturates. And we'll address some of these in the specific scenarios as we start to go through these. So I'm going to go through these relatively briefly. The intoxication-related agitation that shows up in our department is certainly probably one of our most common presentations. And in many ways, it's one of the easier ones to actually deal with. You may be able to de-escalate and redirect these patients, but often you may end up needing physical restraints, at least transiently. And sometimes you are going to need medication for the really agitated, intoxicated patient as well, but you know it's going to be a relatively well-defined time frame. Often we tend to favor antipsychotics in these types of patients over benzodiazepines because we know that they've already got a sedative depressant on board if they've been drinking, and we want to try and avoid too much of the way of benzodiazepines in order to try and reduce any risk of further respiratory depression. When it comes to withdrawal-related agitation, Hassan addressed this really beautifully, so I'm not going to spend much time on this, except to sort of reemphasize that benzodiazepines are really the cornerstone of management in this, and we have to really titrate rapidly to symptom-based assessments so that we can try and get on top of this quickly for the patients. Now, the delirium tremens patient is sort of the extreme end of the withdrawal syndrome presentation as well. And part of the challenge with this is actually recognizing it in the patients when we're seeing them. And so sort of thinking about the diagnostic criteria that you need for this. So these are patients who are obviously agitated, but they've also got altered sensorium. So they may be having hallucinations, they may be quite disoriented. They're often vitally abnormal in terms of being tachycardic and hypertensive, sometimes hyperthermic as well, and diaphoretic in the setting of recent cessation or cutting back of alcohol. And this is a very important condition for us to recognize because it's got a not inconsequential mortality risk, much lower now than it used to be in the past, but still something that's fairly significant. And as we approach the management for it, benzodiazepines still are really important, and we need to titrate those aggressively as we do with other withdrawal syndromes. But then we'll often end up adding neuroleptics to try and address some of those perceptual changes and hallucinations. That, however, isn't always going to be effective in these patients. And if you look at the recommendations in the literature, it's often phenobarb that's quoted as the next drug of choice. That is a drug that nowadays very few emergency physicians have really a very high level of comfort with. And in many places, it may not even be stocked in your emergency department anymore because it is relatively infrequently used. But as Hassan mentioned as well, there is a role for drugs like propofol in these patients for sedation. And this is something that you may end up needing to initiate in the emergency department, though the ultimate disposition of these patients is often a much more monitored environment, like an ICU or at the very least a step-down type of bed. And those are things that you obviously need to be monitoring the patients very closely with And sometimes even in the ICU environments, you'll see drugs like dexmedetomidine used for sedation, which has a clonidine-like effect, which can be very helpful in this circumstance, but it's not as available as frequently in the emergency department. And again, not something that most emergency physicians have as a high a level of comfort with. So it tends to depend much more on your local resources. Now, the mixed presentations is probably one of the most common areas that we actually see. And when I say mixed, this can be mixed substances, so alcohol and something else, or alcohol and another pathology. And this is probably one of the areas where we have one of the greatest pitfalls in the ED management of agitation, because here's where we tend to fall prey to our cognitive biases and the risk of missing another diagnosis because there's an assumption that it's only related to the alcohol intoxication. But we have to think about other mental health diagnoses. We have to be aware for other organic disease. So maybe this patient is an alcoholic who has not been taking his insulin and been on a binge for the last several days. And so now he's in DKA. And if you don't think about it and you don't investigate for it, you may not recognize it. Or it's the patient with the subdural who's fallen down and injured their head. In terms of the management of this, this is often where the combinations of drugs are used quite frequently, that Haldol and Ativan combination. And there is evidence from the literature that helps support why that actually is. And there was a systematic review by Korczak back in 2016 that looked at benzodiazepines alone, antipsychotics alone, or the combinations of them. And the combinations were shown to be more effective than single agents in almost all measures. But you can still be a little bit nuanced in this in terms of adjusting your approach for the patient that you see in front of you based on what symptoms seem to be more predominant. So if it has a much more psychiatric feel to it with hallucinations or paranoia or disinhibition, you may lean a little bit heavier on the neuroleptic dosing and a little bit less on the benzodiazepine dosing. Whereas if it's very sympathomimetic in terms of the presentation, you may be much more aggressive with the benzos, which are excellent for sympathomimetic effects, and you may be using a little bit less of the neuroleptic type drugs. Haldol is still the most frequently neuroleptic that's used neuroleptic in emergency departments, although there are others that are available to us. Our colleagues in psychiatry quite like loxapine, and you'll see it used frequently there as a parenteral option. It doesn't seem to have enjoyed as much popularity in emergency departments, and I suspect it may be because you can't combine a benzodiazepine with the loxapine in a single syringe, which I think a lot of practitioners find is a little bit limiting for them. When it comes to the benzodiazepines, again, lorazepam is commonly used in combination with the neuroleptic, although you can certainly make an argument that midazolam may actually be a better choice pharmacokinetically in terms of its rapidity of absorption and the effect that you're going to see in terms of the time to sedation. While it is shorter acting, there are circumstances where you might actually want something that's a little bit shorter acting so that the patient can wake up and be a little bit more accessible for you again. And then lastly, we'll have to look at the patient with the agitated delirium. As I mentioned earlier, agitated delirium really is not a pure alcohol-related phenomenon. There's typically some sympathomimetic stimulus involved in this as well, but alcohol may be a component as a co-ingestion, and you may get that as part of your history when these patients present into the emergency department. And in fact, some of the clinical criteria and elements of the presentation actually look like they overlap with delirium tremens. But these patients with agitated delirium have really severe agitation. They tend to be incoherent and virtually unengageable. They're tachycardic, they're diaphoretic, they're tachypneic, they may be hyperthermic as well. And you'll often see descriptions in the literature that they seem to be impervious to pain and to fatigue and are capable of unusual strength. But overall, the literature is relatively weak in this area because it is a relatively rare presentation and it's much harder to study. But this is an area where ketamine has been put forward as probably the best drug to use for the initial control of the agitation and in order to achieve some sedation for the patient. And there are a couple of papers that do support this. Riddell published in 2019 a paper looking at the ketamine as a first-line treatment for severe agitation. And Lin also in 2020 did a randomized study on this. And while neither of these studies were perfect, they both showed fairly convincingly that ketamine has a significantly faster onset of action than any of midazolam or Haldol or a combination of those drugs. And really, it is the time to sedation that is really critical in these patients. They're very hard to physically restrain, and you have to be very careful in the physical restraint of these patients because there are numerous case reports of people having arrests and deaths that are felt to be related to pressure around the neck and pressure around the chest in the process of trying to physically restrain these people. And once they do have a cardiac arrest, the likelihood of a successful resuscitation is actually very low. Most of these patients will die. So you want to achieve control of these patients fairly quickly because then you need to start to address all of the other metabolic effects. And many of these patients are significantly acidotic. They may be hypoxic. Rhabdomyolysis is common in these patients. You may see hyperkalemia as well. And they really are at elevated risk of cardiovascular collapse. So these patients really need a resuscitation environment, further workup, and you may end up needing to really control these patients completely and take their airway even after just the ketamine dose. So lastly, I want to just talk about what I think are a couple of opportunities that we have as a profession to advance the care of these types of patients in emergency departments. It wasn't really that long ago that EDs were ERs. They were actually just rooms with a few stretchers in them and some curtains in between them. But over time, we evolved and we changed in response to the needs of the communities that we serve. And across our country right now, we're seeing increasing volumes of mental health and addictions visits in emergency departments. And I think that we really need to design so that we can serve that population better. And when I say design, that can be something as simple as making sure you've got a stretcher that's set up to restrain patients and a place to do it that is more conducive to the care. Or it might be something as significant as designing a secure unit within your department that makes the management of these patients easier and more humane. And we're in the process of doing that right now at Sinai Health, and several of our peer hospitals around the GTA have done exactly this and have mental health units within or attached to their emergency departments that allow them to better manage these patients in a more efficient way. I think that there's a real role for simulation in improving the care of these patients. And it can be something that you're doing in the sim lab, or even better, do in situ simulations. It's a wonderful opportunity to do a multidisciplinary and collaborative exercise. And you can get your nurses, your physicians, your social workers, your security people, your psychiatry consultants all involved in this. And I can pretty much guarantee you that if you do this, you'll learn something about the way that you're doing it that will improve your processes and make the care better for the patients. I think that there is also an opportunity to debrief some of the difficult cases around this. Many departments now debrief all cases with bad outcomes. A lot of cases are doing quick in-department hot debriefs for routine resuscitations in the department as well. And just like when we debrief those cases, you get all the relevant players involved. You get RT back to do the debrief. You get the consultants back, and you do a quick hot debrief in the department. Bring your security guards back, because if there was a really challenging case that was difficult or stressful or hard for the clinical staff in the department, it was hard for the security people as well. And involving them and is something that will give you further insights that is also going to allow you to improve the care, I think. I think you'll really learn something from doing this. With a little bit of practice, hot debriefs can be done in actually just a few minutes. And lastly, I would say that it's no secret to anybody, I think, who's actually listening to this, and certainly not the speakers who are here tonight, that alcohol use disorder has huge personal and societal costs. And we might do a great job with the management of the patient in that specific episode of care in the emergency department. But if there's not access to follow-up, it's likely that there's just going to be a repeating pattern of this. So I think we need to use and leverage our experience to advocate, to utilize collaborations and partnerships within our organizations and within our local communities to help improve the care. And this might be things like adding addictions consult services to your organizations. Maybe it's setting up rapid access addiction medicine clinics for better access to your patients after discharge. But I think that we as a profession really need to be part of this and engaged in it if we really hope to see change in this area. And with that, I will apologize again for the technical difficulties, and we will stop and take some questions.
That's great. Thank you very much, Dave. And I think there's one question here. It comes from T. Kumar. How do you administer the volume of ketamine required to achieve sedation? I've often heard the 5 milligram per kilogram IM dose, but in practice, I can't see how that would be given in a single injection.
So that's a great question. You have to look at what you actually stock in your department for ketamine. It comes in different concentrations. So in my department, we've got the 100 milligram per 1 mil dose, which means if you're giving 500 milligrams, that's 5 cc's. Now you can give that. That is the upper limit for an IM injection. If you're injecting in the thigh or in the gluteal region, you can't give that kind of volume up in a deltoid. But that is still within the dose range for what you can do for an IM injection. And you're right, you really want to try and do it in one dose if you can, just to minimize the risk. Although certainly you can split it into 2 doses if you need, either if you have a larger patient or if your staff is not comfortable with doing that single dose.
Great. 2 comments. One from Michelle Clayman, 2 syringes, both arms at the same time. And another one from Dominic Shelton. Nice to hear from you, Dominic. Ketamine 50 milligrams per mil instead of 10 milligrams per mil might be a solution. So those are interesting ones. We've gone about 10 minutes longer than I had planned. I want to thank everybody who's still with us. I know that there's still close to 100 people online, so that's remarkable. To have such a large group on a Wednesday evening. So I'd like to thank everybody for participating today and coming to these rounds. I'd like to thank our speakers, Hassan, Michelle, and Dave, for your insightful comments. I'd like to thank CAEP. I'd especially like to thank Paul Pajot for the invitation, Gail Chapman, Caroline Lapierre, Shanna Scarrow, and everybody else at CAEP for making this possible. I'd like to thank Jeff for your technical expertise in keeping the wheels on the bus through our moments of drama. And I'd like to tell everyone else, if you have questions that we haven't had time for, there were a lot of questions which came in. If you could please email them to Shanna Scarrow, it's SCARROW at cape.ca. She's put that in the chat. Shanna will forward on your unanswered questions to me, and I can distribute them to Dave, Michelle, and Hassan for answers so that we can make sure that we're able to get to everything. And I guess with that, I'll tell everybody it's time to go have dinner or more painfully watch the Raptors, which started 10 minutes ago here in Toronto. Well, in Tampa. Anyways, thank you, everyone. This has been wonderful, and we really appreciate everyone coming. Have a great evening.